Thank you, sir. Thank you for this excellent lecture and for approach to anemia. Now there are few questions that has been raised during the talk. So the first is, if the patient with Thal minor has iron deficiency anemia, RDW would increase, right? So can
Correct.
this serve as a clue, or we need something more to look for?
I would say you have to do, suppose you are sure this is a Thal carrier. You've done a hemoglobin A2 and it is more than 3.5%, right? So you know that. Now, does a person with iron deficiency have a raised A2? The answer is no. There's good data from Delhi, Roshan Kulla's data, which shows that almost never does the A2 go above 3.5%, right?
Okay.
So if you have a A2 which is more than 3.5%, you've got a diagnosis of Thal minor. If the A2 is between, say, 3.2, like that, then you have to do a molecular test to confirm, particularly if this is a lady who's planning to have kids, right?
Okay.
If you have a raised RDW and in a person with Thal minor, I believe you must check a ferritin. Why? Because you do not want to load a person with Thal minor with iron, and therefore please do a ferritin. Ferritin low, A2 raised. Diagnosis is a combination of Thal minor with iron deficiency. Treat the iron deficiency, and the patient should do well.
Okay. The second question is, there are diseases like lupus and HIV where it is the multifactorial anemia. Though history serves as the key, what would be the starting point in this kind of cases?
I believe that the main thing that you need to do, right? I think, in fact, what foxes the resident most times is when the anemia is multifactorial, right? Otherwise, most of them will get it right. So I'll give you an example. Person has got GI bleeding. The GI bleeding is chronic. By the time the patient becomes iron deficient, is not able to produce a retic response. So then you can't use the retic there to separate a production problem from a loss.
True.
Right? So the anemia now becomes multifactorial. That means blood loss was the primary cause, but it was chronic, and therefore there was iron deficiency, which blunted the retic response. In this case, you will have to go by the history carefully. So if you find that yes, two local blood is positive and the retic is low and the ferritin is low, then you've got your diagnosis of GI bleeding, loss of blood, secondary iron deficiency anemia, which is doing this. Now next comes to the more complex problem. How do you diagnose iron deficiency anemia in a person who has got chronic inflammation like rheumatoid arthritis? In a person with rheumatoid arthritis, you have the anemia of chronic inflammation. When there is inflammation, the hepcidin levels are raised. When hepcidin is raised, the macrophage does not release its iron for erythropoiesis to happen. Actually. So the future treatment of anemia of chronic inflammation is going to be a hepcidin blocking antibody. We don't have that yet, right? So today the resident is faced with a person who's got rheumatoid arthritis, whose ESR is 100, whose hemoglobin is 8, whose Coombs test is negative, so he doesn't think there's hemolysis. The reticulocyte count is low, so he's a bit foxed. Is it just anemia of chronic inflammation? Or is it anemia of chronic inflammation plus iron deficiency? Right?
Yes.
So these were the type of patients where we used to do a bone marrow for stable iron. Right?
Okay.
Today, we will use a serum transferrin or transferrin receptor assay because the transferrin receptor does not go, it goes down only if there's iron deficiency, and it doesn't go down when you have anemia of chronic inflammation. So we use the serum transferrin receptor because ferritin is an acute phase reactant and it will go up when you have rheumatoid arthritis with a high ESR. So this is one situation where if you don't have a transferrin level or a transferrin receptor level, then you've got to do a stainable iron for bone marrow.
Okay. Okay, sir. Thank you. The next question is, what is the expected time to raise retic count after giving supplements?
Okay, so once you start iron, please remember there was an article in Blood about 2-3 years ago saying that when you start oral iron, don't start Livogen if you're using Livogen or Orofer XP twice a day. If you give a high dose of iron, that will actually push up the body's hepcidin level. And when that happens, the transfer of iron from the epithelial cell of the duodenum into the plasma is reduced. So today's approach is start with a low dose, 1 tablet a day, wait for a week, then go up to 2 tablets. And there's a beautiful study in Blood which showed that you should start with a low dose, right? So what is the recommended dose? In the good old days, it was 60 milligrams of elemental iron, which comes in a 200 milligram tablet of ferrous sulfate, and you give it 3 times a day. No matter what the reps tell you, all the more expensive preparations of iron like Fefol, etc., or Dex Orange are no better than plain and simple ferrous sulfate. I am a bit of a fan for Livogen because it's not so expensive. It has a little bit of folate in it. And I start with 1 a day for a week, increase to 2 a day and 3 a day. At one of Dr. Agarwal's CMEs, I believe it's no longer fashionable to give oral iron. So the recommended treatment is NC-carb given intravenously as the treatment of iron deficiency. So I asked Dr. Agarwal, if Usha has anemia, will you give her NC-carb? He didn't answer, right? So I still believe there is a place for oral iron, but there are people who are not tolerant. They either get constipated or diarrhea, or they just refuse to take it. And for those people, I think NC-carb is a good solution. And in fact, the risk of anaphylaxis is like very, very, very low. So it's quite a safe thing to give. And when do you expect the reticulocyte response? I usually check after 2 weeks. If you're on the right track, the retic count will start coming up in 2 weeks' time, but the safest is 4 weeks. If your retic has not come up by 4 weeks, by 4 weeks, your hemoglobin should come up by 1 to 1.5 grams, right? So the earliest is a retic count at 2 weeks after starting therapy should rise and usually does. And by 4 weeks, your HP should come up by 1 to 1.5 grams.
And sir, for B12 supplement?
Now, B12 supplementation, you must be careful, okay? Suppose you have a patient with a hemoglobin of 4, an LDH of 5,000. This person is actually having massive destruction of developing red cells inside the bone marrow, right? That's why the LDH is so high. Now, in this particular person, the caution is that when you give B12, you suddenly switch ineffective erythropoiesis into effective erythropoiesis. serum potassium can come down. So you can have sudden death after you start B12 replacement. So always the rule is don't give folate alone for a person with a megaloblastic anemia, right? You must give B12 first or both.
Yes, sir.
Right? Because folate by itself can worsen the neurological problem related to B12 deficiency. So always combine, if not give your B12 first. Now, what is the dose? Right? Now, the methylcobalamin comes as a 500 microgram dose. The daily requirement of vitamin B12 is 1 microgram per day. And most of us have 1000 micrograms in our liver, which is why after a total gastrectomy, it takes approximately 2 years for you to develop megaloblastic anemia, right? So if you give an intramuscular dose of 500 microgram, more than 2/3 will be lost in the urine because it's water soluble. But even 1/3 will give you enough B12 to last you 3 months. But most of the books say give B12 once a week into 4 doses, then once a month into 3 doses. I generally don't follow that rule. I think 500 microgram once a month for the next 3 months is more than adequate to build up. And the earliest response to therapy by day 5, the reticulocyte, the LDH will fall by 50%. So if you had a 2000 LDH, on the 5th day, the LDH will come down to 1000. That's the best indicator of response to treatment. And always check the potassium, supplement syrup KCl, because suddenly when erythropoiesis becomes effective, your potassium all goes into the cell and you can get hypoketonemia.
Sure, sir. If a patient having mixed anemia, sir, iron as well as vitamin B12, so how to diagnose?
Okay, this is a tough job, right? Because one of my earliest patients in Australia was a severe megaloblastic anemia with a serum iron which was elevated and a ferritin which was elevated, right? Now, why does this happen? This happens because there's no effective erythropoiesis. So iron is not being utilized, and therefore the serum iron goes up, the ferritin goes up. Once you give the B12, the ferritin crashes, right? Because there was a combined B12 plus iron deficiency, right? So what I would suggest is start your B12, right? You are suspecting that there is an associated because the blood picture is dimorphic or whatever. I would say if you repeat the ferritin 2 weeks after starting B12, ferritin will crash. And then you have your diagnosis that yes, there is a combined deficiency of B12 and iron.
There is one more question. What is the difference between serum ferritin and serum ferritin receptor level?
Actually,
Transferrin.
yeah, actually, see, as I told you, no, when iron enters the cell, there is a protein which is formed called apoferritin. So the intracellular iron binds to apoferritin and then gets deposited as ferritin inside the cell. So the protein which is formed inside the cell is apoferritin and the deposition is as ferritin. And therefore, the intracellular ferritin, for some strange reason, correlates very well with the serum ferritin, which is why we use ferritin as an indicator of iron overload. Right? It is also a very good indicator of iron deficiency, except when you have chronic inflammation and the ferritin is pushed up artifactually by the chronic inflammation. Right? Now, as I told you, the iron can be bound in the plasma to transfer it. So the protein which carries iron in the plasma is transferrin. Okay, and the red cell can take up transferrin bound iron. It cannot take up free iron, or it has to be presented on transfer, right? So when you have iron deficiency, both the transferrin level goes up because it's desperately looking for iron, and the transferrin receptor on the red cell goes up because it's trying to grab as much iron as it can from the plasma, right? So these two are not affected by inflammation, unlike the ferret, which is why that is the gold standard for iron deficient. But it's an expensive test. It costs 300 or 400 rupees. Therefore, you can complete your iron therapy without doing that. But there is one situation where you want it, and that's anemia of chronic inflammation associated with iron deficiency.
Okay. The next question, if during this time, if PCV has been given, still this will be effective or not?
If what has been given?
If red blood cell has been transfused to the patient, ERBC, then still the test is effective, or will it get manipulated and we have to wait for 4 to 6 weeks?
I am not sure of the answer to that question, but I don't think it's affected by transfusion, because the transferrin and the transferrin receptor are present on developing red cells. Once the red cell has become mature, it loses its surface transferrin receptor because it can no longer take up iron. Because mitochondrial synthesis of hemoglobin has stopped, there is no fresh mRNA being formed because the red cell is anucleate.
Sanket, there are some questions in open chat box also.
Yes, sir. I'm coming to that also.
Okay.
One more question is, sir, if you have iron deficiency anemia in a young male, your stool local blood is negative, how aggressively you should consider for lower GI or upper GI scopy?
Sanket, I have made a mistake one too often. Okay, I had a person with angiomatous polyp in the small intestine. He kept coming to me with iron deficiency. I did multiple stool occult bloods. They were negative. Till one day he landed up in the emergency with an intussusception. Right? So I believe that any patient with iron deficiency anemia, which is not straightforward nutritional, needs a GI evaluation for blood loss. Right? I've had a teacher from Kerala, 45 years old, came to me with iron deficiency anemia, referred to the gastroenterologist, gastric ulcer, biopsy, no malignancy. Started on H2 receptor blocker and sent home. Came back 6 months later with bilateral Krukenberg tumors. Right? So what was a curable disease when she came with iron deficiency? Right? So please, if you have a gastric ulcer, tell the patient come back after 4 weeks for repeat scoping. Right? So screening for gastrointestinal blood loss. This is why I get the patient and then I have to send to gastroenterologist, right? So basic is upper GI endoscopy, colonoscopy. If both those are negative, then you have to check the small intestine. And that is the most difficult thing to do, right? Recurrent iron deficiency anemia, checking out the small intestine in a young patient is important. First, do a technician scan for a Meckel's. If the Meckel's is negative, then you have to do a capsule endoscopy. Then you have to do a check for bleeding by doing a scan. So I believe I have made the most mistakes in small intestinal bleeding by delaying picking it. Right?
Oh.
So 3 sites, upper GI endoscopy, colonoscopy. Negative, stool occult blood positive, chase for a Meckel, that's negative, then the most common cause is either a hematomatous polyp or in older people, an angiodysplasia.
So studies have suggested that in tobacco consumers, incidence of anemia is more than non-tobacco user. What could be the mechanism?
I honestly don't know because I haven't sort of checked. In older people, I would say don't miss out a malignancy because malignancies of the GI tract are much more common in people who use tobacco in any
Okay, sir. Yes, sir. Role of leucovorin in megaloblastic anemia?
uh, see, folate is very easily absorbed, right? And it is absorbed from the jejunum, right? So the only indication to give folate as folinic acid is if you have used methotrexate. The other reason is because there is no parenteral form of folic acid, right? Folic acid is only available as an oral form. It's not available as a parenteral form. If you want to give parenteral folic acid, then the only way to give it is as folinic acid.
Uh, Patient having iron deficiency anemia diagnosed at the time admitted for some other acute illness like mucor or septicemia or AKI or something else. Should we give iron or should we wait?
That's a $1,000,000 question. And I had a patient with thalassemia, right? And I gave her chelation with deferasirox, right? After a transplant. Don't ever do that, right? Because the deferasirox grabs the iron and makes it available for mucor to grow, right? So you can give desferal, but not deferasirox, right? So there is this thesis that iron facilitates microbial growth. It also facilitates the growth of fungi like mucor. So I would say yes, be careful. If there is iron deficiency, anemia, and mucor, I would rather you give red cells than iron supplementation because mucor is a life-threatening problem. You've got muted, Sanket.
Sanket,
For other indications like sepsis or any sepsis or AKI patient is admitted, will you give iron at that time?
Patients with the biggest users of parenteral iron are our nephrologists because they don't like starting erythropoietin without being sure of adequacy of iron stores, right? So they tend to replenish with parenteral usually and then start the erythropoietin. That's not an unreasonable practice. I think it's okay. But a person who comes with acute sepsis, I would prefer not to correct the iron deficiency with iron at that time because there is definite evidence that microbial growth is increased by iron. But I've never seen anybody saying, yes, if you give iron, the septicemia will worsen. No.
Okay. Your opinion on sir carbonyl iron, is newer preparation?
I think NC-carb is the preparation everybody's using, and I think it's much better than the good old preparations that we used to use intramuscular, which was horrible because the skin became black. I think the carbonyl iron is a very safe and good way to administer iron, and the total dose infusion protocol works beautifully outpatient, and there's no problem.
The role of Menzer index.
I don't use any of these indices now, right? Because I don't think they're infallible. I mentioned the RDW. All of those indices are based upon the fact that there is anisocytosis in iron deficiency. There isn't anisocytosis in thalassemia. So I think today at 400 rupees, a hemoglobin A2 is the better way than to do any of these indices as the diagnosis. Because you cannot use this index and reassure the patient that everything is all right. Patient gets married, has a baby, and the baby is Thav major, and particularly in Gujarat, they will kill you if that happens, right? So don't go by indices, go by an A2 level.
I think, Sanket, one question is left. Is sublingual
Yes.
B12 a replacement for injectable B12?
Is which B12?
Sublingual tablets are available of B12.
Yes, yes.
So is it replacement for injectable B12 or not? That is.
Actually, it is. There is a 1 milligram tablet of sublingual, and as I told you, the requirement is only 1 milligram. Nuisance, yeah. So on most of, I have a few patients with Imerslund Grasbeck syndrome, right? Now this is a syndrome where in the ileum, they lack a receptor which binds cobalamin, right? They also can have proteinuria. And I've got about 4 or 5 patients with Imerslund Grasbeck syndrome, right? It's a rare disease, but it's nice to make the diagnosis. And they come to me once a year for one shot of B12. So which would you rather do? Put one tablet under your tongue every day or just take one shot once a year? Because if you give 1,000 micrograms, that will last them for a year. If 2/3 is lost in the urine, you still have at least 300 micrograms, which will last for 1 year. So I generally prefer to give parenteral, but I agree with you that we can give it as sublingual.
What TIBC suggests?
See, the TIBC is a test. Nowadays, I generally don't bother with doing TIBC, but if you want to do an additional test over ferritin, and I showed you know, that in anemia of chronic inflammation, both TIBC and serum iron come down so that the saturation is maintained. So it's an indirect, simple test to separate iron deficiency where the iron binding capacity goes up and the serum iron comes down and the percentage saturation is reduced.
One more question, sir. Malaria with hemolysis and LDH is 642. Any role of steroids?
The answer is no. I wouldn't give steroids for a person who has got malaria-related hemolysis. Now, please keep malaria in mind, okay? I've given you one list, right? And that list is fairly obvious, actually. So a person comes to you with uh, fever, which is every second or third day, and you suspect malaria, please remember that even today, malaria is something which must be excluded when a patient has a hemolytic anemia. Right?
When will you go for IV iron? And again, the same question, how safe is isomaltose compared to carboxymaltose?
I have only data on the carboxy maltose. I don't know enough about the other preparation. And I believe it's extremely safe. I've given it to many patients now, and I don't have a problem with it at all. But please do not believe that parenteral iron is faster than oral iron. It is not. The retic response occurs at the same time with oral iron as with parenteral iron. So if you think that I want to give IV iron because I want it to work fast, the answer it doesn't work any faster as oral iron does. Right? The retic response is the same. In fact, the carbonyl ion is taken up by the macrophages and then released for developing erythropoiesis. Please also remember that in a person with rheumatoid arthritis, when you give parenteral iron, there can be a flare of the joint inflammation after you give the parenteral iron. So warn the patient. Otherwise, they will think, hey, this guy has given me this iron and my joints are hurting like mad. So warn them before you give, if there is a arthritis problem.
Sir, blood transfusion, how many days we should wait for electrophoresis?
Blood transfusion versus checking for electrophoresis, right? There are two situations. One, if it's a thal major, right? Now, in a thal major, you expect the fetal hemoglobin to be more than 90, 95, 98%, right? Now, if you give transfusion and then check the fetal hemoglobin, for some reason it doesn't come up, and then the patient gets diagnosed as something else. To my eternal shame, one very rich patient came to me having had multiple transfusions. I was not doing molecular and velo at that time. Fetal hemoglobin was 7, 8%. She had been transfused repeatedly. She went to London, and to my shame, she was diagnosed as thalassemia major in London. Right? Now, you don't want an Indian hematologist to send a thalassemia to London for diagnosis. Okay? So please remember that the fetal hemoglobin fails to come up after transfusion, and therefore you must check parents for hemoglobin A2 and do a molecular study. Today it's very easy to get a molecular test done, so don't depend on fetal hemoglobin level in order to diagnose thalassemia major in a patient who has received transfusion.